Welcome everyone, send our greetings. My name is Anita Shet and I'm the Director of Child Health at the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. And it is such a pleasure to extend a warm welcome to all the panelists, participants, and listeners to this webinar co-hosted by the International Vaccine Access Center, IVAC, and the Every Breath Counts Coalition. The title of this webinar today, in a way, says it all: the human cost of pneumonia and the power of the PCV, as you can see in the slide, the first slide. PCV, or the pneumococcal conjugate vaccine, as you all know, protects against life-threatening pneumonia and meningitis. And pneumonia caused by pneumococcus is one of the leading causes of death among children under 5 years of age and also among the elderly. And the vaccine against this pathogen, PCV, was a welcome advance in our efforts to control pneumonia and its complications. And in the year 2000, PCV became available in high-income countries, and the price was initially set high, such that only a handful of countries were able to introduce it to their populations. And due to unprecedented collaboration and support from Gavi, and world agencies such as the World Health Organization and UNICEF and others. And I just wanted to continue talking about the vaccine and how in 2017, India introduced PCV subnationally in a phased manner with Gavi support. And in 2021, India announced that the vaccine would be available to all children in the country, preventing many tens of thousands of deaths in children under 5 years, and also preventing many, many times that number in terms of cases and suffering among families. And Somalia is a country that is on the cusp of introducing this life-saving vaccine and will contribute further in global child mortality reductions. In our webinar panel today, we have a scintillating array of speakers from India, Somalia, and from Gavi and IVAC, who will discuss the human cost of pneumonia and the opportunities and challenges in PCV rollout and impact. And the discussion is moderated by my colleague, Dr. Chizoba Wanodi. And it's an honor to introduce Dr. Wanodi. She's absolutely committed in improving access to childhood vaccines worldwide. So she is a technical advisor for the Immunization Agenda 2030 and the immunization lead for the USAID's Momentum Country and Global Leadership Program. Chizoba is an associate scientist at the Johns Hopkins Bloomberg School of Public Health and the Nigeria Country Director at the school's International Vaccine Access Center. So over to you, Chizoba.
Thank you so much, Anita, for that kind introduction. Good morning, good afternoon, and good evening to the hundreds of participants, I am told, who are logging into this webinar today from almost 50 countries. I'm really excited to be moderating this session today. And before we get started, I wanted to do a few housekeeping announcements. First of all, we're going to have 2 places where you can interact. There is a Q&A session that, that you can put your questions in. There's a Q&A box that you can put your questions in, and we'll get to them after the presentations. And there is also a chat box. So feel free to go ahead and introduce yourself in the chat box and enter any other comments that are not questions. This webinar will be recorded and available for viewing after today's presentation. So it will have a second life after this live viewing. And thank you so much for attending. Today, we will address successes and challenges around life-threatening pneumonia. We know we have powerful pneumococcal conjugate vaccines. And as Anita has very clearly pointed out in her opening remarks, PCV vaccines are available to more children than ever before. Yet, the pandemic has threatened progress in many ways. How? New vaccines introduction have stalled and immunization coverage has dropped. And in doing this, it has actually erased a decade of progress we have made in vaccine coverage, with shocking increases in the number of children who have received no vaccines at all. It is estimated that just less than half of the world's children receive a complete course of PCV. This is much less than 90% coverage target by the Immunization Agenda 2030. And this Immunization Agenda 2030 is a plan that has been endorsed by all countries to mobilize commitment resources around immunization. Today, I'm very honored and pleased with the talented and committed leaders and advocates from global agencies, governments, and civil society that we have assembled for this August panel to discuss and highlight the high human cost of childhood pneumonia and to discuss progress to prevent pneumonia in Somalia and India. I'm honored to introduce our first speaker. She is Ms. Veronica Denti. Veronica coordinates Gavi's pneumococcal and rotavirus vaccine program. And in that role, she brings together technical partners and assists countries to navigate Gavi's support. Veronica, over to you.
Thank you. Thank you so much, Dr. Wonodi, and welcome everyone. And thank you also, Dr. Shet, for welcoming us all to this panel today. I have a couple of slides with a few photos also to share with you all to just set a little bit the stage on the good side of the story and perhaps the remaining side of the story of human cost of pneumonia. Let's start where it begins. In the next slide, you will see what is the recommendation made by our colleagues at the World Health Organization, updated recently, that shows and reaffirms that every country worldwide should include the pneumococcal conjugate vaccine, also known as PCV, as a complementary intervention to disease prevention and control measures of pneumonia. And studies in low and middle income countries have really reaffirmed the value of these vaccines. There are three keywords on this slide and why I wanted to really reaffirm it. One is worldwide. The second is complementary, because the vaccine is one of many interventions. It prevents the vaccine preventable pneumonia. And three, low and middle income countries, because that's where the highest burden of disease is today, with the exception of China. If you can go to the next slide, the question is, so how many countries, given that it should be worldwide, do offer the pneumococcal vaccine to their children? We're looking at the younger children from 0 to 1 year of age today. And the number is an encouraging one. It's 148, of which, if we go to the next slide, you'll see that 60 of these are in the Gavi supported countries, which tend to be the bottom up 70 poorest countries in the world, defined by income. Now, what you see on this map, if we pause for a moment, is a lot of green. Green is always good. The green means the countries have introduced. But you also see some yellow, which is also good. And you'll see in a moment where we stand there, meaning there has been progress. Either there is approved Gavi support for these countries to introduce a pneumococcal vaccine at the Gavi price. And why this is important is because, as Dr. Shat mentioned, price had been a barrier more than 10 years ago to introduce these quite expensive vaccines in low-income countries. But thanks to the alliance that Gavi brings together, it's really an alliance of partners. This price has been negotiated lower and lower to make it a lot more affordable for countries to start paying for it and adopting it. In the next slide, we'll see what this means in terms of impact. So the impact up to today has been phenomenal. In the last decade and a couple of years, more than 255 million children have been reached by this vaccine. This is a staggering, staggering number. And the primary engines of this result have been countries. Of course, larger countries more than smaller ones, but the primary engine have been the governments, the ministries of health, the ministries of finance, the EPI managers, and all the healthcare workers from the central, the regional, the national, the local periphery level that have reached these many children. It's a massive result that translates in 700,000 estimated deaths averted, which, if you allow me, I like to think about it in terms of potential life saved, but technically deaths averted. And yes, 1 in 2 children was reached by the vaccine. You can see it as a glass half full or half empty. 1 in 2 children is more than the global average today, and yet it leaves a second child to be reached. Regrettably, though, this was all just before 2020, when the pandemic hit. And there was more progress planned, as we can see in the next slide, but that has been a little bit slowed down. So you should see actually the on track should have been green. Apologies, some of the colors got changed. So there's been progress in India, as Dr. Shet mentioned, huge efforts in scaling up across more and more states. And this is really a salute to the Indian government and to all the healthcare workers that have contributed to make this happen. Indonesia has announced last year another scale up to bring the vaccine nationwide, and I think we'll see it happen this year. And those are large countries that will really lift the numbers of access even further. We also had Ukraine ready to launch in 2022. We also have Timor-Leste approved to receive access to the Gavi prize. Tajikistan made a massive effort to be the first country to receive approval, not only to launch in routine, but to launch with catch-up, meaning to reach children that are between 1 and 5 years old that have been missed in the last 4 years, to make the impact of this effort even bigger. We know that there is commitment, we don't doubt it for a second, but given the priority of the COVID-19 pandemic mitigation, we fear there might have been a slight delay in implementing this year, so we've added 2023 as a timeline. Now, this was already planned, and we were hoping this to happen, but there's more, because as you've seen in the earlier map, in the next slide, we can see what else is a gap that we can aim to close. And I hope that the scientists in the audience will accept my non-traditional interpretation of the data. I'm showing a graph that shows deaths averted in the green. And what you're seeing here is data estimated from 2019, actual deaths across 5 countries that we know are eager to assess and find a way to introduce this vaccine soon in their routine vaccination program with Gavi support. These are Chad, Somalia, South Sudan, and Guinea. We also know these are countries with particular challenges, particular fragile situations, and we're looking within the Alliance for all the support that we can bring together to really support this lift from the red, which is the estimated children lost, to pneumonia as a whole in this country every year, lift them up into the green, which is the estimated 1/3 of lives that can be saved, with some optimistic assumptions on how many children can be reached. But this is really the vaccine preventable aspect of pneumonia. This is really where we shouldn't have any excuse to hold back. And I optimistically put the start of this change in trend in 2023, hoping that by then we will have gathered enough support and momentum to translate the potential into a reality. I have 2 more slides. Next one, please, Andrew. This is a slide that is very necessary to add today, because none of the past progress, none of the future potential will ever be made possible unless so many partners in health come together and support. All of these, you can see here, many more even separately, be it tools, be it local support, be it policy guidance. There is so much work that goes into this, and I just feel super privileged to be able to try and do a little part in this coordination mechanism that Gavi brings. And finally, it's a picture from Haiti from 2018 at the launch of the pneumococcal vaccine. And here you see the child that has been vaccinated with his father and with the healthcare workers and the WHO local staff and the Gavi colleague that have helped bring this reality together for the country in Haiti, and that we hope to replicate in so many more. Thank you so much. Dr. Wonodi, back to you.
Thank you so much, Veronica, for that exciting presentation. I see that a lot of progress has been made. Many countries have introduced PCV, but there's still much more that we need to do. Several children who don't have access to the vaccines in the countries that have not introduced PCV. And to illustrate why this is so important for every child to have access to PCV, I would like to show you a preview of a short video that tells you the human cost of childhood pneumonia. As they say, storytelling is one of the most powerful ways to put ideas into the world. So enjoy this short documentary, and please be sure to check out the full video. Andrew is going to post the link to the full video in the chat.
अनि ज्वरो आएको मम्मी मलाई त ज्वरो आयो भने पढेर स्कुल गएर आएपछि
फोन गर्यो अनि फोन गरेपछि अनि के भयो भनेर चाहिँ अब उदिनैखेरि म आउनु चाहिँ
ल्याएपछि झन् छैन अनि छोरी निरुता त बिहोसमै लगाएको हो मैले त
झाँक्री लगाए नदेखेपछि अनि हाम्रो जबरजस्तीले नै अनि यहाँ झाँक्रीको मात्रै भर नगर्ने अब हस्पिटल लाने भनेर एम्बुलेन्स बोलायौँ
म चाहिँ अब रुने अब मेरो छोरी के पो हुने हो
अनि त्यहाँको चाहिँ मेन डाक्टरलाई बोलाएर गर्दा कुन चाहिँ डाक्टरले यसो गरेर आज रात पनि काट्नलाई गाह्रो पर्छ यहाँ हुँदैन उपचार अनि सबै त्यो पाटन हस्पिटलमा पैसा भन्ने कुरो चाहिँ मसँग त्यतिखेर जम्मा 6000 पैसा बाँकी रहेछ खल्तीमा धेरै मान्छेहरू चाहिँ भने कि अब भेन्टिलेसनमा हाले मान्छे 1000 मा 100 मात्रै हुन्छ अनि त्यही माथि चाहिँ 4 जना त्यही रुमबाट 4 जना चाहिँ लास्ट निकाले बेच्नु भन्नाले चाहिँ यहाँ बेचबिखन गरे भने चाहिँ खाट पलङहरू थियो कुर्सी टेबलहरू त्योहरू चाहिँ सब अल बेचे
त्यही मात्र हो बेचेको चाहिँ गोरु मात्रै अर्थको चाहिँ अब छैन पनि
लाख भन्दाखेरि माथि खर्च गर्छ सबैभन्दा डर लाग्ने भन्ने विषय नै अब डर सबै चिजमा डरै डर के छ कस्तो छ यो भन्दा नि ठिकै भयो हुन्छ कि हुँदैन कि तँलाई कस्तो के भइरहेछ तेरो लागि चाहिँ म जे गर्न पनि म जति जे गर्न पनि म तयार छु तँलाई सुधार भयो कि भएन हुन्छ कि हुँदैन त्यस्तै भनेर चाहिँ सोधबुझहरू पनि गरिन्थ्यो बोल्न पाए कहाँ कस्तो भइरहेछ सोध्न पाइन्थ्यो
Indeed, that was really touching. When we hear the stories behind the statistics, the names behind the numbers, we know that childhood pneumonia is something that we need to address really quickly because of the suffering that it brings. So I would like to thank the producers of the video, Patan Academy of Health Sciences and Oxford University in partnership with IVAC. So moving on from there, it's my honor and pleasure to introduce the next two speakers Dr. Morsal Abdi. He works as a general practitioner at a hospital in Somalia, Somaliland. And after his speech, will come on Dr. Rajiv Seth, an American board certified pediatrician working as a medical director, as the medical director, Child Health and Development Center, managing trustee, BUDS, New Delhi, India. So this is my great pleasure to introduce these two speakers, starting with Dr. Abdi.
Be presenting for Dr. Mursal, as he has excused him as he had a emergency issue to deal with today. And
thank you.
If you excuse me, I will present on his behalf.
Okay, thank you so much for stepping in. Over to you.
Thank you very much. I hope everybody can see on the screen.
Yes, we can see your screen.
Childhood pneumonia is common in developing countries like Somalia. One of the greatest challenges is in the delay in seeking appropriate care or not seeking any care at all, which contributes to large number of pneumonia deaths in developing countries like Somalia and Somaliland. Medical intervention is always required for bacterial pneumonia, but in most cases, children can be treated at home. In addition to antibiotics, they need plenty of rest and need to keep up their fluid intake. Next slide. This is the story of Mohammed, an 8-month-old boy who was suffering from a cold, cough, and fever. These are the symptoms that the child presented with. His mother, Amran, gave him some medicine and did panning dots at the anterior and posterior aspects of the chest following the advice of her grandmother, who is a traditional healer in her village, and she treats pneumonia. Pneumonia in Somali is called Oforen, and so the grandmother is the traditional healer at Adashina district. That's an IDP in Hargeisa. And this is a common that most Somali people are not literate, particularly I will present in the women. One of the health challenges is the lack of literacy. They don't have, most women are illiterate. The literacy is high in women. And for this reason, they seek medical intervention from the traditional healers, non-medical personnel, which usually use banis and herbals to treat. Like in this case. Unfortunately, after 5 days, Mohammed's condition deteriorated. A community health volunteer visited the family as part of her household visit plan. She found that Mohammed was suffering from a severe respiratory illness and advised his mother that he may have pneumonia and she should take him to public hospital. Next slide, please. Amran was hesitant due to the high cost of treatment at the private health centers and hospitals since her prior experience with her 6-month-old son, Seki, who died from pneumonia following treatment at both a health facility and hospital for 14 days. The community health worker reassured Amran and said you can rely on the public maternal child health and hospitals because they are affordable and the service provider is trained on pneumonia management, and your son is in the early stage of the disease and has chance to refer higher level facility. So this is a photo of Dr. Mursal and the child with mother. Next, please. Amran decided to take Mohammed to tertiary health facility, which is the highest level of health service providers in Somalia, the Gates Hospital, Referral Hospital. And fortunately, Dr. Musal was in his duty at that time at the outpatient, and she became one of his patients. And when she entered his room, she gave this story, and he assessed Muhammad's condition. Vital signs were feverish, 39 degree Celsius on the axilla, and respiratory rate was 30 beats per minute. Pulse rate was 120 beats per minute, and oxygen saturation was 89. Bilateral basal crackles were also present. He diagnosed him with severe pneumonia and admitted the child in the ward and prescribed IV medications of Triaxon and paracetamol. The baby responded to the medication and recovered well during 3 days in the ward. At discharge, she also was advised to come back to the hospital, hospital outpatient for a follow-up. Mohammed did a full course of antibiotic and was fully cured. Amran thanked the community volunteer and the Hargeisa Group Hospital Pediatric Department staff, saying, "I am forever grateful to those people who saved my son." Next slide, please. Mohammed's story illustrates how timely and appropriate treatment of pneumonia at the community level can save the lives of 6 children who may never reach a higher level facility. Next slide. This is the second story, and it's about Holo, a 6-year-old, and had a cough, fever, and lower chest pain for 3 days, and then was getting very tired. Holo's mother thought she has had a bear. That's a Somali word who derived from traditional Somali healers, and they think that the liver problem can cause such symptoms. She consulted a nearby traditional healer, women who confirmed that Hodo could have a hepatitis or bear. So actually, bear is all diseases that affect the liver, including hepatitis, and did scratch burns around her tummy immediately. It's another case of treating many conditions with burns or burning the child. Her condition is worsened, and Holo developed difficult breathing and couldn't sleep much, and she ate very little for 2 days. She also complained of stomach ache, and so her mother kept her home from school for 5 days. Holo started feeling better that weekend, so she returned to school. The following week, she would still get run down easily, but was not complaining of any pain. It wasn't until the second week of being unwell that her mother thought there may be more to this illness than just a bear hanun or a liver problem. As Hodo appeared quite pale and started coughing up red-colored sputum, and her breathing had become quite shallow and labored. Next slide, please. Hodo's mother took her to the hospital where she was diagnosed with pneumonia based on her symptoms. The doctor didn't order a chest x-ray as Hodo had contracted pneumonia in the past, and the doctor was confident in diagnosis. The GP also prescribed antibiotics, and Hodo to rest and keep her fluid intake up. Hodo stayed home the following week and slept a lot. She started feeling better after about 4 days, but would still get tired easily. She lost weight around 2.25 kg in those 2 weeks. Hodo returned to school the following week with full recovery after completion the course of antibiotic and antibiotics. Next. After our experience, I would advise parents, this is as Dr. Mursal's experience, I would advise parents to take a sick child to the doctor for advice with a delay and be aware that pneumonia can present itself in many different forms. And actually these stories mainly give an insight into the delay and lack of education for mothers, and the problem of traditional healers' misconceptions, like treating every disease with panics or panning the child and doing more harm, and also delayed and seeking of healthcare. Thank you, and
Thank you so much.
over to you.
Thank you so much, Dr. Mohammed. I'll now invite Dr. Rajiv Seth to take over the stage. Thank you.
Thank you very much. Can you hear me?
Yes, we can.
Okay, great. Greetings from New Delhi, India. It's a privilege to be speaking to all of you. India is a low middle income country with a population of 1.3 billion. We have 26 million babies born per year, and our under 5 mortality is very high. The IVAC study of 2020 estimated that 640 children die per day due to pneumonia in my country. I would quickly like to take you to my next slide and take you to Mewat. You can see in this map, the region red is Mewat, Haryana. This is the most backward aspirational district of the country based on the Niti Aayog Government of India ranking based on the developmental indices. At BUDS or Bal Umang Drish Sanstha, we've been operating a custom fabricated mobile medical van here to provide access to primary healthcare services. In addition, we also provide access to vaccinations, child welfare services, and also do research to improve vaccine confidence and remove any hesitancies. This is my team, and I'm really privileged to be speaking. The next case, next slide, please. This is a study. This is a child who came from a poor village in Mewat in the mobile health van with a 4 days history of cough, cold, fever, breathing difficulty. The child was breathing fast, tachypnea, tachycardia, had signs of moderate dehydration, acute malnutrition, but staff made all the efforts and referred this child to a local government hospital where he received oxygen, IV antibiotics, supportive care. Really fortunate that this child improved and discharged. The X-ray was suggestive of pneumonitis. Next slide, please. Many children are not so fortunate. They die and succumb to a very severe pneumonia. But this child, really, we're very fortunate that we were able to have a success story here. Next slide, Andrew, please. So in this region, there are lots of high-risk factors, but notable amongst them are children who have low birth weight, malnutrition, non-exclusive breastfeeding, and unvaccinated children, children exposed to pollution. These are at high risk of development of pneumonia. Now, you will all agree with me that each human life is precious and every experience is unique. We see a lot of social determinants in Mewat. Social determinants to health include poverty, illiteracy, ignorance, people living in the margins with lots of hardships, child marriage, name what may. But what happens is if the child gets suddenly sick, say with pneumonia, and is hospitalized, it also endangers them, their loss of livelihood. This is something, most of them are daily wage earners. The huge cost of treatment, isolation, puts the family under a lot of mental stress. Next slide, please. Now I will take you to this second case. This case is not mine. I picked up from another doctor who was treating. I was consulted as a second opinion for reference. And this child was from a well-to-do family. Both the parents were family physicians. They were living in urban Delhi, but they chose not to take PCV vaccine. This child developed fever and cough for 5 days, was admitted on day 6 with breathing difficulties, hypoxia. His labs and counts showed high WBC counts. There was also evidence of right lobar pneumonia, as you can see on the X-ray. This child was given multiple antibiotics right away after all the cultures were drawn. The antibiotics included augmentin, amikacin, as well as ceftriaxone, all in one sitting. And after 48 hours, the doctor realized that the child is not improving, is still hypoxic. He added more antibiotics called meropenem, linezolid, and clindamycin. Subsequently on day 7, the child expectorated a lot of sputum, and some of the gram stains showed a gram-positive diplococci suggestive of a strep species. But what I got anguished was this child had received so many antibiotics. And when we have a global as well as national problem of antimicrobial resistance, why should a child receive so many antibiotics? And this is one of the reasons I'm presenting. And I'm supporting vaccinations and PCV vaccinations. Next slide, please. Yeah, so these are the counts. Next, please. No response to the treatment. So you see, vaccines can decrease antimicrobial resistance by preventing infections. They can reduce misuse of antibiotics by physicians. There are lots of causes that you can go on, and I think vaccines have a big role and they have a power over this as well. Next slide, please. Now, India has several challenges. The recent COVID pandemic disrupted our primary health services. We all know that immunizations, the routine vaccination services are disrupted, and it is threatening all the hard-won gains which India has made. The 2020 IVAC study has reported that 1 out of every 5 children who is hospitalized with pneumonia would need oxygen. So oxygen gaps have to be bridged. And you can prevent more pneumonia deaths if you have oxygen supplies, great infrastructure, and physicians, human resources, and pediatric ICUs, or whatever is needed to prevent and treat life-threatening pneumonia, at the same time doing all vaccinations. Next slide, please. India has done remarkably well since its national health mission, and the 2014, the government's mission Indradhanush started with 7 major vaccines and massive strides were made, but yet the child health has been daunting. Next, please. You see, pneumococcal vaccines have been now launched in 2016-17. It was 5 states, and now with the recent 2021, the budget speech of our finance minister has launched it all over the nation, and we believe that 50,000 deaths will be prevented. There's a PCV-10 which is locally made in India by the Serum Institute called Pneumosil. But I want to draw your attention to the high prohibitive costs. Still in the private setup, a PCV-10 vaccine costs about $26, about 2,000 Indian rupees, and the PCV-13, which is the Prevnar vaccine, costs about $53. This is way up high what a daily wage earner earns, just about $6 per day. We're fortunate to have had support from Gavi, and they supported, and now the government of India launching it shows their commitment to preventing pneumonia deaths. Next, please. I want to draw your attention to this BUDS work, which is done with the partnership for the Johns Hopkins University and the Johns Hopkins Maternal and Child Health Institute. And I'm really privileged because, when I've been working in Mewat for the last 17 years, many times we would say the government vaccinations were there, the staff, the A&M, and everybody was there, yet people did not come forward to take the vaccines despite community mobilization efforts from door to door. And this has been a big challenge to me and my colleague, Dr. Taneja, who jointly does a lot of health education initiatives in Mewat. So this particular grant to improve routine immunization coverage has really helped us build some infrastructure in place to translate local policy and advocacy across the social ecological model. Most of you in IVAC are familiar with this model, and what we are essentially doing are created a cadre of 20 frontline peer leaders who are being engaged with co-creation workshops and developing social media communications, developing slogans. We've created a cadre of youth champions and designed, again, social media campaigns around them. We have done institutional training of the frontline health workers, first when there was COVID online through a grant, and then delivering through, education and training through into and engaging with the health workers in Mewat has been crucial. But most important, the first time I saw the religious leaders and the impact they have on improving vaccine confidence. And when the religious leaders, so we've engaged the Malanas and also the public leaders, the Sarpanch, the village self-government. So the entire spectrum is now in place. And we really, next slide, please. Because of the lack of time, I can't say, but I must say this is a schematic diagram of what a vaccine knowledge hub looks like. We have established 2 of them. The space of one was donated free of cost to Buds by the Sarpanch because he appreciated our long-term work of reaching out pro bono for mobile health van and primary health care services. The second one also has been given by a owner who feels very gratified and thankful for a child we saved from vesicorectal fistula with repeated sepsis episodes. So essentially, this vaccine knowledge hub, we are training community members across different levels of socio-ecological model, and we are creating an impact. And I think the environment has to be created where community responsibility ownership has to take place, and vaccine should be perceived as a basic right of a child. I want to look forward to the day where the parents themselves come, that it's the right of the child to get vaccinated, because that's the only way forward rather than doctors telling what them to do. Next slide, please. This is a set of slogans which are developed by peer readers. They are from the community. They know the community. They know what is going to impact. They are in Hindi. We have shown it to our district immunization officers, and they've all appreciated, and they want to take this forward. Next, please. This is my last slide. There's so much of engagement. We've done engagement with community matter, with puppet shows, with bike rallies, with focus group discussions, outreach through our pamphlets. And we have created movies. We have invited the Saloni Sharma. You can see her. She's one of the sub-divisional magistrate who opened and inaugurated our vaccine knowledge hubs. Dr. Indra Taneja is going to schools. The Maulanas are also helpful. And, this is something that, we want to see. And we invite you for a visit to Mewat to see these projects. And also invite you for your attention and your support to continue to support this project beyond its, 6 months period. Because, this is a lot of hard work has gone. And I really want to appreciate and thank Anita Seth, the director of the program, and also her team, Kayur, Asta, if they're listening, Pritika, Buds team, if they are listening, for all the support, because without your support, this project wouldn't go anywhere. So thank you very much, and hope we can succeed in the drive to eliminate polio, not only in India, but worldwide. Thank you.
Excellent. Thank you, Dr. Seth and Dr. Omar, for those presentations. We've heard from Somalia and India that childhood pneumonia knows no geographic boundary. And Dr. Seth highlighted the social determinants of health that affect a child's risk of acquiring pneumonia. We also heard that vaccinations have the power to not only reduce morbidity and mortality from pneumonia, it also helps to reduce antibiotic resistance that arises from overuse of antibiotics in treating bacterial pneumonia. I think that's very, very powerful. Thank you so much, Dr. Seth, also for sharing some of the innovative approaches and advances that you have put in place to advocate for pneumonia in India. So I will go on now to invite the next set of panelists. It's my pleasure to invite Ms. Vandana Gunani. She's currently on study leave, and she is the Additional Secretary at the Ministry of Health and Family Welfare with the Government of India. After her will be Dr. Mohammed Omar Obe, who is a physician who serves as a National ICCM Manager for Save the Children Somalia Country Office. Dr. Gurnani, please, the floor is yours.
Thank you, Soba. I would be sharing today India's journey, and I think it's really a privilege for me to be able to share this journey of introduction and scale up of the pneumococcal conjugate vaccine in India. But I'd like to begin with a salute and tribute to the frontline health workers who made this journey very successful and made this possible despite the challenges that we all encountered on account of COVID-19, because a large part of this journey of ours, of the scale up, was covered during the COVID-19 pandemic. Next slide, please, Andrew. I'd like to begin with the context of the universal immunization program in India. It's one of the largest public health programs globally. Our annual target that we hope to cover is 27 million newborns and 29 million pregnant women. There are now 11 nationwide vaccines against the vaccine preventable diseases. And there is one vaccine which is against JE, which is only subnationally in the districts of the country which are endemic to JE. Previous slide, please. There are 12 million sessions which are planned every year. And there are 29,000 cold chain points for storage and distribution of vaccines. And this has been possible due to systematic health system strengthening over the several years. There's also an IT platform to monitor the supplies, the inventory management, as well as the health of the cold chain equipment. We're also fortunate to have a large manufacturing base within the country of vaccines, which supply vaccines to the entire world. Thank you. Next, please. Yeah, so coming to the disease burden, pneumococcal disease burden in India, we have 824,000 children who die in India before their 5th birthday in India. Out of these, 15.9% deaths are due to pneumonia, which include both the postnatal period and the neonatal period. In 2015 alone, it was estimated that Streptococcus pneumoniae would cause annually 1.6 million cases of severe pneumococcal disease, which would include severe pneumonia and meningitis, and 68,700 deaths in the under 5 children. Next slide, please. Next slide. Yeah. So this is how the entire decision-making process panned out for the PCV introduction in India. As many other countries, India also has what several countries call their NITAGs. We call it NTAGI, the National Technical Advisory Group on Immunization, which is chaired by the Union Health Secretary, as well as the 2 scientific secretaries of medical research and biotechnology, and comprising of several technical experts and academicians who contribute to this process. So early on in December 2014 itself, the Standing Technical Subcommittee, which supports the NTAGI, did a review of the disease burden in the country, also reviewed the vaccine efficacy, including cost efficacy, and gave its presentation and recommendations to the NTAGI. In August 2015, the NTAGI made a recommendation to introduce the vaccine within the country and recommended 2 primary plus 1 dose so that it could be timed with the existing doses or existing schedule of vaccination to avoid any extra visits by the child and the parents. In January 2016, the rest of the, the 2 steps include the administrative steps, the National Health Missions Empower Program Committee, and then the Mission Steering Group, which is chaired by the Union Health Minister and several other ministers of the Government of India. They recommended the introduction of this vaccine. Subsequently, the phase-wise rollout of the vaccine, which state, which one's on priority based on disease burden, those details were worked out by an expert committee. So this is what the details of the administrative as well as the scientific processes that were followed before the vaccine was introduced and scaled up in the country. Next slide, please. So the introduction happened in 2017 in 5 states or 5 provinces of the country. This is a picture of the first baby girl who got the vaccine on 8 June 2017 in district Hamirpur, Himachal Pradesh, where the vaccine was launched by the then Union Health Minister. The Mother and Child Protection Card, which has all the vaccines indicated, was also updated to include this new vaccine in the card. Next slide, please. Coming to the expansion, as I said, the initial launch was in 5 high-burden states, and there was initial catalytic support from Gavi to start the vaccination process within the country. Subsequently, the launch of Pneumosil, which is a Make in India product, which was launched in December 2020, it enabled the country to have a nationwide scale-up beyond Gavi's initial catalytic support. And this nationwide expansion was announced in the budget by the Union Finance Minister in the budget speech of 2021-22. And this is exactly a quote from the budget speech, which said that this Make in India product, which is limited to 5 states only, will now be rolled out across the country. And this will avert more than 50,000 child deaths annually. So what we can see here is that I just wanted to also clarify with respect to Dr. Rajiv's presentation. In India, close to 98% of the kids access vaccine in the public sector. And in the public sector, the vaccines are completely free of cost because they're procured and supplied free of cost by the government of India. So apart from impact on the Dalis and Heelys in terms of mortality and morbidity, there is also impact on out-of-pocket expenditure and on catastrophic health expenditure on account of this new introduction. Next slide, please. This is the pan-India rollout. So 31 additional states, which is 50% of the cohort introduced in 2021, which was the peak of the COVID period. So what we show here is the blue states are the one where it started initially between 2017 and 20, and then it was scaled up in 2021. Now all 36 states have PCV in their immunization schedule. All the infants have access to it, and 100% of the birth cohort has access to it. Till February of this year, about 75.18 million doses have been administered. Next slide, please. So coming to the challenges during PCV, because while the ship started sailing very smoothly, the boat was completely rocked by the storm of COVID. And during the storm period, we also wanted to expand PCV countrywide. So there were specific challenges in terms of ensuring that preparedness assessment takes place, which was traditional paper-based manual assessment in the past with physical visits taking place. So it was difficult to track the progress using this conventional method. Capacity building was challenging, getting people together for trainings, physical training, which were done hitherto was difficult. There were difficulties of net connectivity in certain places for online trainings. The challenges in this period were also on account of the change in the PCV products because a new product was available domestically. So the earlier states had to switch to this new product, which was available as part of the domestic production. And the supply chain was already overburdened with the COVID-19 vaccination that was happening simultaneously. Next slide, please. So some of the strategies that were implemented to overcome these challenges include an online tool that was developed called the PCV Rollout Monitoring and Preparedness Tool. This was developed as a digital solution. It was user-friendly, it was online and interactive, which helped the frontline workers to make the assessments, the states and district to assess, and for the national government to monitor them. There were also online and hybrid trainings that were conducted, and these were conducted flexible timings, especially late in the evenings, because the same machinery of the healthcare worker were also carrying out the COVID-19 vaccination. The cold chain capacity was assessed, and new cold chain, wherever it was needed, was supplied from the Government of India. IEC prototypes were developed and provided to all the states. These included print as well as electronic and social media product like short videos for WhatsApp, etc. Next slide, please. Coming to the procurement and interchangeability. So when we moved, the first 5 states was PCV 13, Prevnar, and this was introduced initially. Later states had to switch to the PCV 10, which was a domestic product. However, the WHO recommendations on interchangeability made this possible, and this was informed to all the states, and necessary trainings and capacity building was conducted. Next slide, please. So this is celebrating the expansion of PCV in India. This is the Union Health Minister with the team in the ministry. And this is a celebration of the Pan-India rollout, which was done on 29th October 2021, when this entire, all the states, the rollout was complete. Next slide, please. So in terms of the key learnings from this is that there was a very, very high level political commitment, starting from the Prime Minister to the Health Minister and the Finance Minister for this nationwide rollout. There was funding support from the Finance Ministry for the introduction as well as the expansion. The availability of the domestic product and timely procurement obviously helped in the pan-India rollout. Immunization partners all worked alongside the ministry in ensuring that the rollout happened across the states and the districts, especially in terms of capacity building and the IEC. Digital preparedness assessment tool helped in the timely submission of data analysis, especially during the COVID times. Next slide, please. The online training opportunity was used to conduct trainings with flexible timings, thereby increasing the participation. While the system was overburdened due to COVID-19, but at that time, the dialogues immunization were very predominant in the public domain. And this is what really helped and spurred the PCV rollout also. Timely supply of vaccine to the state ensured seamless availability across the cold chain points and sessions. So this required very meticulous planning by the Health Ministry to ensure that they reach at all the last mile points in time. Then there was also intense communication strategy and media coverage, which created the demand for the vaccine. So this is in very brief. Next slide, please. This is in brief the journey of India, and I only can hope that with India introducing and scaling up the vaccine, and as Gavi puts it, there would have been market shaping that has happened, and hopefully with this, the glass that is still half empty would not be half empty, and this would spur action across the world and make sure that the balance 50% of the children also get this vaccine, and not a single child is left without this vaccine against a disease which can be completely prevented with vaccines. Thank you.
Thank you so much, Dr. Gunani, for that powerful presentation. It was really wonderful to hear about the phased PCV introduction in India. Now we have it in all 36 states, meaning that all children in India have access to this vaccine. And you also rounded up nicely by giving us some of the key lessons that you've learned, from having political commitment, having a domestic product, leveraging partnerships right down to the communication strategies. Thank you so much. So I will call on Dr. Bobe now to please take over. Dr. Bobe.
Thank you very much, Chisoba. Next slide, please. I will start straight away. I will start with saying that Somalia is and has also other challenges other than health, which affected the health, like Somalia has been in turmoil and lack of central functioning government. So the health system was entirely destroyed, and the health system relied on the support of the international community support, the aid support. So most of the health and child health indicators like pneumonia are actually among the worst in the world. And as you see in this slide, pneumonia is the leading cause of child death in Somalia, and with 24%. Actually, some in literature say some of the sources say 25. That means 1 in every 4 children that die in Somalia dies from pneumonia, followed by diarrhea, malaria with 19 and 3%. Neonatal disorders are actually the second, the third. So pneumonia is actually the leading cause, and it's also the least actually focused until recently. Next slide, please. And the treatment coverage rates for children with suspected pneumonia are low in Somalia. For example, 34% of children with pneumonia symptoms sought treatment or advice from a health facility or provider. That's according to the Somali Health and Demographic Survey of 2020. That's the latest data we can get. And 21% of children with pneumonia symptoms received antibiotic treatment, and according to the Somali Health and Demographic Survey of May 2020. And that's a very low figure. And this, okay, I will mention it in the next slide. Please go to the next slide. Many barriers prevent children from accessing healthcare in Somalia. And mostly, and this is one of the biggest reasons, is financial barriers. According to the Somali Health Demographic Survey in 2020, 61% of women reported financial barriers as major reason for not seeking healthcare. 58% of women reported distance to health facility as major reason for not seeking healthcare, including 76% of women from nomadic settings and 64% from rural households and 48% from urban. And this is mainly because the health system coverage in Somalia is very low. The health facility number of health facilities is very low, and this is mainly concentrated in the urban areas. And the rural and nomadic actually have limited and health access. And next, please. But a portion of children vaccinated overall for all antigens, 13% of children aged 12 to 23 months received all basic vaccination. That's according to the latest data of Somali Health Demographic Survey, and that's, you can see, is very low. And you see the antigen, TB or tuberculosis, BCG is 30%, DTB is 42%, and HIP for 42, 46% measles, and polio 47%. So next, please. Proportion of children vaccinated for PCV, as you see, PCV is not introduced, rotavirus is not introduced, and they are zero. And you can, so Somalia is actually applying and is preparing for introduction of PCV with the support of Gavi. They are eligible countries that are eligible to Gavi support. Next, please. Save the Children is actually one of the biggest partners in Somalia Health, and actually they are among the they are maybe the biggest, maybe next to UNICEF. Save the Children supports the Ministry of Health in the provision of immunization services by providing training to the health workers that provide EBI services, and we provide also incentives to the MOH staff that provide EBI, because the Ministry of Health is not able to provide salaries as the country's finance actually budget for health is very low. We also support the monitoring and supervision of the activities. Save the Children advocates also for the introduction of PCV in Somalia, and for the last 5 to 6 years, Save the Children actually has spearheaded and the advocacy for PCV introduction, and also to bring pneumonia on the spotlight as the biggest contributor of child mortality and morbidity in the country, and have been holding a World Pneumonia commemoration. First, they actually introduced it in Somalia 5 years ago. As you see in the picture, these are the Ministry of Health and Save the Children staff commemorating World Pneumonia Day. And the photo is in 2019. Save the Children actually advocates for the introduction of PCV with the information and the availability of new vaccines that are affordable and also be provided by the WHO in the market, like pneumococcal, and this is now actually getting a momentum in Somalia. We also support by strengthening the EBI system program for immunization, and as I said, incentives capacity building and strengthening the cold chain system. Save the Children on its own even runs over 400 health facilities in Somalia and 336 community health workers that provide integrated community case management of childhood illnesses, and numerous, but the turn-up is actually the mobile teams is stop and start. So I don't want to mention the figure here, but the mobile teams are even more than the health facilities, and they provide immunization services and other child health services. Next, please. So generally, in Somalia, there's a high commitment for PCV introduction. There's a lot of sensitization and now awareness of the burden of pneumonia for the last year. That work has been done for the last 5 years, and Somalia now is preparing to introduce PCV in maybe latest by 2023. Thank you, and over to you.
Thank you so much, Dr. Bobe. Indeed, you've made a powerful presentation demonstrating why Somalia needs the PCV vaccine introduced. That's great. So right now we have answered most of the questions in the chat. Thank you so much for the questions. So I'm now going to focus on questions for the panelists. My first question goes to you, Dr. Bobe. We saw a video showing that the pneumonia disease is not just devastating to children's health, but also affects families emotionally and financially. Have you seen this in Somalia? Have you seen families maybe selling possessions, animals, or even furniture to pay for pneumonia treatment? And how did that make you feel, seeing this human impact of pneumonia?
And thank you very much, Chisoba. I have seen many actually and very impactful and stressful stories of pneumonia. As I was working in Somalia, I worked as a health worker, frontline health worker, and as a program manager for health programs. And I remember at the time we were introducing a community health program, ICCM, in one of the districts that don't have health access. And I asked one of the fathers, do you think that this is an important program? And he said yes, because he has lost his 2 children to pneumonia. He have traveled with his child on his back for around 30 kilometers to a nearest health facility, and the child died upon reach of the health facility. The second case also happened with the second child with the same father. And for the third case, it was the community health worker that we have operationalized that saved his child. Save the Children provided referral system support, like an ambulance to the community, and the community health worker had a phone to call the ambulance when she sees an emergency case or severe case of pneumonia that she can't handle. So he was very appreciative, and he was saying that that he lost 2 children, and the third one has luckily was saved by the community health worker. The Somali community actually have been in war for 30 years, and the government is rebuilding now, and the economy is very poor. The health financing is of the Ministry of Health is around 3% of the meager sources of the Somali government. And so the population, and around 65% of the Somali population are rural and nomadic. And that means they keep livestock. So when a girl gets sick, that means they have to sell either a cow or a goat and they have to travel for a long distance. So the stories there of pneumonia and the health problem in Somalia, actually,
Really
whether it's they selling them the high cost of finance, whether it's the distance to health facilities, whether it's the lack of protective vaccines, and actually it's actually devastating.
That's really heartbreaking. Thank you so much for that. Really heartbreaking. I'm going to turn over to Dr. Seth now in India. Dr. Seth, since New Delhi introduced PCV in 2021, have you seen any impact on hospitalization? Has there been a change on, children being hospitalized for pneumonia? Dr. Seth?
Yes. This is really a short time period to say that. But what we are seeing in our offices and our clinics and our communities that serious infections are on the decline. We have less reports of pneumonia as such, and these are like we don't have a published paper from India to say that for sure right now. But whatever evidence we have from our clinical practice, yes, it is making a dent, certainly.
Okay. That's good to hear. And hopefully papers will come out, but from your own experience, there's been a great impact on that, on hospitalization.
Absolutely.
Okay. Yeah, thank you. I also want to ask Ms. Gunani, so let's look at how the vaccine is being rolled out in India. So as the government of India, you told us it's now rolling out PCV to all children in India. What impact do you expect to see on pneumonia hospitalization as vaccine coverage expands?
So as I said that before the vaccine was introduced, there were all the studies done in terms of the disease burden, even in terms of the DALIs that would be averted by the introduction of this vaccine. And as you can see in the speech of the finance minister, it is clearly indicated that it would avert about 50,000 deaths if it is rolled out at scale in all the states in India. In terms of hospitalizations also, one would expect that these should go down. And as Dr. Rajiv said, it's too early right now to be able to have any data to speak for this. But knowing that this is a very effective vaccine in terms of the DALIs that could be averted, one would expect to see this change over time.
Thank you. 50,000 deaths is quite a number of deaths. And again, we're looking for the data to really push this message forward. Thank you. So Dr. Bobby, I'm going to come back to you. We've heard from both the health minister and the ministry that the Somalia government would like to introduce the PCV vaccine, but they need additional support to do so. What is the role of organizations like Save the Children to help the government achieve its vaccination goals, and what needs to happen for Somalia to introduce PCV before 2023? That's before next year. Dr. Bobe.
Thank you, Chisoba. I will start with what needs to happen before the introduction. And as I presented the coverage of the current antigens or immunization vaccines that are now provided in the EBI, the coverage is very low, and that the reason is because of capacity issues, like the cold chain capacity of infrastructure, the health staff capacity, the motivation of the staff, even the reporting or the HMIs. They usually say there's a lot of under-reporting, and those areas need to be strengthened, and that will be a good role for the health partners and international NGOs to support in that, prepare the system or the health system for the introduction of the PCV. In that advocacy, there is also a role in that advocacy. There's the Somalia, and as I said, is the health financing is very low, and because the government budget is low, so the government health system depends on the aid or the international community support. So co-financing is very difficult for the government of Somalia. So either advocating for a waiver or a partners to take up the role and contribute to that. And so the partners actually have a great role to play in the advocacy, in the preparedness of the system to the introduction, and in the co-financing. Over to you. Thank you.
Right. Thank you so much. I think I want to really echo that the importance of supporting Somalia on this, whether it be the co-financing or strengthening the systems. And that brings me to my next question. And this goes to Veronica, Ms. Denty from Gavi. Somalia is one of 8 Gavi eligible countries who have yet to introduce PCV vaccine. And this is, they are in the same company with Chad, South Sudan, Guinea, Comoros, Syria, Tajikistan, and North Korea. These countries have not introduced the PCV. What can Gavi do differently to help countries like Somalia and others introduce PCV before 2023?
Thank you so much, Dr. Wonodi. This is a very hard question, and it's a question that we have been busy with, and it has a number of answers. Number one, we know that these countries have a different type of challenge. They are considered more fragile. And for the pneumococcal vaccines, but actually for all the others as well, Gavi has reorganized the way that we work. So we now have dedicated staff for the group of countries that fall into the fragile definition, like all the countries that you have mentioned. And we are looking more and more at tailored approaches to support them through tailored staff and tailored policies. For pneumococcal specifically, I keep asking internally, what else can we do? Right now, I think there's a huge focus from partners and advocates that are helping lift Somalia. And what we're looking internally is how else can we share evidence? How else can we make the transaction cost lighter? Because when there's limited bandwidth, even the interaction, the gathering of all the data, these exchanges are really a heavy load for any country and fragile countries in particular. And how can we perhaps facilitate the case for investing in pneumococcal vaccines and the return on investment so that the financing aspect can also be eased. So those are certainly aspects that we're very actively involved in looking at. In addition to that, we're also considering perhaps to incentivize a joint application also with the rotavirus vaccine to really make the most of this effort of having the most impact when this momentum comes that a new vaccine can find a way into the national routine immunization program to really maximize the impact, reduce the transaction cost, and ease the access to financing.
So are we hoping that there will be positive movement, positive results before 2023 in Somalia?
I'm hopeful that the momentum is there. I'm hopeful that the focus, the resources are there. I am optimistic that by the end of 2023, we will have all the pieces in place. Yes, I am. That said, we've heard also all the challenges from the country, and on that, it's, there's multiple players that need to come together, but I've never seen as much momentum as now. So I'm certainly hopeful.
Thank you so much. I didn't want to put you on the spot too much. All right, so we're going to just round up now. We bring in back Dr. Anita into the conversation. Dr. Anita, you have been an advocate for child health for several years, and your work speaks for itself. What would you say is the role that IVAC can play in closing the PCV introduction gap? Can you tell us more about that?
Thank you, Chizoba. And, as you heard from this fantastic discussion so far, we have very good vaccines against pneumonia, and there are more PCV manufacturers being added with time. So while the 143 countries have already introduced PCV in their national immunization programs, there is still a high burden of pneumonia and meningitis and many of these invasive conditions in many countries where this vaccine is not yet available. That many of these remaining countries have expressed plans to introduce the vaccine in the near future. And IVAC has traditionally played a role in widening global access to basic childhood vaccines. And you, Chizoba, and many others at IVAC have been so much a part of this. So, vaccines like the Hib vaccine, rotavirus vaccine, the human papillomavirus vaccine, among others. And in this current project, Closing the PCV Introduction Gap, which is supported by the Bill and Melinda Gates Foundation, our goal is to expand global PCV coverage to positively impact child survival and also quality of life. And for this, we plan to bring together global agencies and Gavi and committed in-country leaders and co-create tailored, targeted advocacy strategies to accelerate equitable PCV introduction and sustained rollout. And IVAC is certainly not alone in this venture. You heard from Ms. Veronica Dente's presentation about the power of partnerships. And so we have unwavering support in this venture from partners such as the Every Breath Counts Coalition and Save the Children, UNICEF, and many, many others. In this project, we have different activities planned, like today's webinar, where we heard the success stories of the PCV rollout from India, which brings hope to many other countries. We're also looking at exploring perceptions of critical stakeholders, such as caregivers and health workers and policymakers, and to facilitate the availability of evidence to in-country leaders. And so that we hope that together we can make a dent in reducing the human cost of pneumonia and the needless suffering of children and families due to this condition that is so preventable.
Thanks, Anita. That's great. Just before we round up, I wanted to squeeze in one question from Alpha Johnson from the audience. And this question goes to Gavi. What is the role of Gavi on supporting LMIC's local vaccine production, specifically for PCV? We heard from India that local production was one of the enabling factors for the scale-up of PCV in India. So I would like to hear from Gavi on that question, please. Thank you.
Sure, and it doesn't have an immediate straight answer, or that one would be short, but there's a couple components that I think are important to highlight. We're receiving these questions from several fronts. So we are looking into addressing it. We don't yet have an aligned public position on what is Gavi's role to support the vaccines made in Gavi countries for Gavi countries outside of the ones that are already available predominantly from India. And we already have two key suppliers there and more. For pneumococcal, there are two. But if we're looking at exploring pneumococcal vaccines in African countries as well, I just want to flag that the demand and the supply balance would need to be very carefully considered. And that's a key role that Gavi has to play. And it's important to know that the demand from Africa for an African-made vaccines might not be as obvious as one might think. Consider the lack of regulatory, quality, safety, long history that provide reassurance to NITAG members when they select a vaccine that is old and that is made in high-income countries, which is what the science of the experts would be more comfortable with. So if we want to support low-income country manufacturers, we need to think about the system, not just the production. We need to think about creating a system that builds trust in the local manufacturing that is beyond just supply, but really the quality, the safety monitoring, and all that comes with it, in order to ensure that the demand will trust and pick up and enable the sustainability of those vaccines. I think this is important because there's always both components that need to go together. Thank you.
Thank you. So back to you, Anita, to round up.
Yeah, thank you. Thank you so much, Chizoba, for this fantastic moderation of this webinar. We're so deeply grateful to all of you panelists for sharing your experiences and knowledge and ideas, and also for coming together today and participating in this webinar. Now, sincere thanks to Leith Greenslade from the Every Breath Counts Coalition, who helped shape the seminar from the very beginning. It's really hard to find someone who is more committed and passionate to the cause of pneumonia prevention. And thank you to ABC and the Gavi team, Veronica, and the PCV steering and subgroup committee for this support. And I especially want to thank the IVAC team from Dr. Bill Moss and Rupali Rimai for their leadership, and especially our team, Jasmine Huber, Rose Weeks, and Andrew Land for planning and executing this webinar. And special thanks to you, Chizoba, as well. And finally, we're really grateful to all of you participants and listeners of the webinar and the questions that you've posed, which really promoted this discussion. And this webinar was made possible by the support of the Bill and Melinda Gates Foundation. So thank you all. Just want to remind you that the webinar recording will be available on IVAC's YouTube channel. So thank you again and goodbye to you all.